So first of all, I'd like to thank the Korean Society for this opportunity to give this lecture. Today's topic I'm going to present is on VATS single port, or another name for its Uniportal VATS, and our experience in the Prince of Wales Hospital in Hong Kong. So to start the talk, I'd like to quote Winston Churchill, former Prime Minister of UK. He once said, "To improve is to change, and to be perfect is to change often." And hopefully we are changing for the better with Uniportal VATS. So if you go on the Medline really and put in VATS in the search in terms of how many publications, you get back around 6,000 hits with VATS. However, if you actually go and search single port VATS, what you get back is around 50-odd publications. So it's only 1/100th of the number of publications in all of VATS surgery in thoracic surgery. In terms of the progress of single port VATS, it all started in 2002 with the first publication of a single port VATS sympathectomy. And then subsequently, there is treatment for pleural diseases and also wedge resection, and also pericardial window, and also mediastinal lymph nodes published in the next few years. There was a relative period of where there weren't too many progress in terms of single port VATS. And in 2011, the first publication of single port VATS lobectomy was published by a group in Spain. The year following that, single port pneumonectomy segmentectomies have been published. And then more recently, their group has reported angioplastic procedures with single port as well as bronchoplastic procedures. And these are the gentlemen who are responsible mainly for the initial publication in these areas. One is Professor Gaetano Rocco from Italy, who published the wedge resection up to pericardial window period. And then Dr. Diego Gonzalez Rivas from Spain, who published the major lung resections. So just going back to 2002, the first true single port VATS was for a sympathectomy. They borrowed a pediatric ureter cystoscope, which is around 8mm device, and they stuck in the chest and they did a sympathectomy for pulmonary hyperhidrosis. In Prince of Wales Hospital, we've made a modern version of this device. We've used a VasoView device, which is an endoscopic vein harvesting device with a built-in endoscope, parallel working channel, and CO2 gas insufflation instrument. And we've also done single port sympathectomy and published in JDCVS with this technique last year. This is an intra-op photo of the device in use with a single port sympathectomy. And we make a 1 centimeter incision bilaterally at the third ICS axillary region to hide the wound. So in Prince of Wales Hospital, we offer sympathectomy in a number of different forms, including 3-port needlescopic VATS with 3mm instruments and scope. We can do 2-port needlescopic 3mm VATS with 3mm scope and also instruments for a sympathectomy. And also we can do uniportal sympathectomy with VasoView device as well as 3mm scopes and instruments as well. If we move on to our experience with pericardial window, everyone knows that that can be done in using open technique, such as through an anterior thoracotomy or a subxiphoid or subcostal technique. The 3-port VATS pericardial window has also been published for a number of years and recognized as an alternative technique for pericardial window creation. And that can be done actually using standard 3-port VATS or needlescopic 3-port VATS. And more recently, we have also adopted a Uniportal VATS for performing pericardial window. So this is the needlescopic VATS, 3-port VATS that we do for pericardial window. And you can see the aesthetic results are fairly pleasing at the bottom. The initial Uniportal pericardial window was reported by Rocco in 2006. And this is how we do it in the Prince of Wales Hospital. Pretty much using standard equipment. We use a 5mm 30-degree scope and also a long tip diathermy and also a retracting device, which can be ranging from a Roberts to specially designed endoscopic devices. The end aesthetic is 1.5 to 2 centimeter wound, and now there are some specialized equipment with a turning tip which can facilitate this kind of procedure. In terms of wedge resection in our center, the first reported Uniportal VATS wedge resection, as I previously mentioned, was in 2004. They published a series on 15 patients. For us, we've been doing Uniportal wedge resection for lung nodules for a number of years now, and more recently we've cooperated with the radiologist in further expanding our service into performing Uniportal wedge resections with hook wire guidance, as you can see from this CT and also the wound and the access, you can see that. So this was the intra-op photo for that particular case. There were a lot of adhesions. It did turn out to be a TB, the nodule that we took out, and we took down the adhesions with a single port access, and then we wedged out the lung afterwards. The aesthetics for this is 2.5 to 3 centimeter incision, and we normally put the drain through the same wound satisfactorily. You can see quite a lot of instruments being stuck through the same wound. It does take some getting used to initially, but it can be done with some patience. The last area I want to just briefly mention is the single port VATS major lung resection. Now, as I alluded to previously, it started in 2011 by the group in Spain. They actually did the operation in 2010 in June. It was a left lower lobe lobectomy for early stage lung cancer, and then subsequently performed segmentectomies and pneumonectomies, and more recently bronchoplastic and angioplastic procedures. This is a picture of some of our patients, someone who's undergone a full thoracotomy on the left side and a 3-port VATS on the right side. The cameraman has hidden one of the ports with the ruler at the back. This is a patient who's undergone a single-port VATS lobectomy with a single wound. We put all the instruments and the scope through the one wound, and the wound is normally around 4 centimeters. So what is happening on the scene in terms of major lung resections for single port? Last year for single port VATS, there was a first World Congress that was held in Naples, Italy, by the Naples National Cancer Institute, headed by Professor Rocco. And actually, single port animal labs have been held in Spain by Dr. Gonzalez in the last year, and is actually fully booked for the next 2 years. He's also delivered lectures on single-port lobectomy in STS and AATS and ESTS meetings. So at the moment, it seems single-port VATS is here to stay. For us, we're lucky to hold our first Asian single-port VATS symposium 2 months ago in Hong Kong, where we invited the experts from the world to perform live surgery, as well as mingled around with 150 delegates from across Asia. These are the photos and the intra-op live surgery that we performed for 2 patients with early-stage lung cancer, and we did lobectomies for them. So how we do it in Prince of Wales Hospital, the equipment that we use a lot of the standard 3-port VATS equipment. There is some specialized Uniportal VATS instruments that are produced by Scanlan that are very nice with a slight angulation. And sometimes for the difficult access or very deep in the chest, we'll use the Storz 5mm angulated instruments, including scissors and the dissecting hook and the coagulation sucker to do our surgery. The Storz endochameleon 120-degree lens is useful sometimes to get the angles to see around the staples where you've placed the staples, to make sure that the structures behind the staples have not been, important structures have not been damaged or inadvertently stapled. Olympus also do an endo-eye deflectable scope where you can help you to look round corners and look behind where you've put your staples to make sure that it's safe. And of course, flexible staplers, as Dr. Miller has described, has really advanced that surgery and made it very much safer. The positioning for us is that the surgeon and the cameraman stand on the same side, patient. In terms of the incision, we quite often get asked how big the incision needs to be. Well, it needs to hold 3 instruments. One is the scope, One is the retracting device, and one is the stapler. So it depends on the size of the scope you use and also the retracting devices. So you need to fit 3 things in through the wound. And our normal incision length is around 4 centimeters. So we don't use rib spreading, just spreading the soft tissue, as you can see. Small incision in the anterior axillary line. A lot of instruments in a small hole, I know, but I can get used to it. And using the flexible or the angulated instruments as well as the scope, you can actually get the angles that you need. Dr. Diego Gonzalez once said it is of utmost importance to coordinate the movement of the camera with the surgical instruments. Now that is very important in single port VATS. That's because with every movement of the camera of the instruments, you're actually affecting the other instruments because the instruments are touching each other, which is very different from 3 ports, where all the different ports are independently in terms of its motion. So movement of one doesn't really affect the other. The other consideration is where the surgeon stands. Normally, we will stand in the cranial part of the patient near the head. However, for difficult cases or when you're doing dissection near the top, sometimes you can swap the position with the cameraman to get the best access for your view as well as for your equipment. Also, you can consider moving the scope at different positions within the wound. The scope, for example, can be at the top of the wound, as in the left of the slide, or it could be at the bottom of the wound. Normally, we won't advise the scope to be in the middle of the wound because it's sort of floating within the wound, then there's lots of movement. So you can move the scope around in order to get the best view and to allow you to place the instruments for your resection. As I said, the movement of any instruments or camera will affect the other instruments. And there will be some degree of fencing that you may experience. And that can be reduced by use of appropriate instruments or rearranging the order of the instruments as I was discussing just now. You can also maximize and utilize angulation of the camera as well as the flexible echelon staplers. Appropriate instruments I've described. Rearranging the order of the scope in relation to the single port wound can help you get the angles that you need. And also using the angulation of the thoracoscope, as well as using the angulation of the stapler, can actually help you to achieve what you need to do in terms of getting across the fissure or getting across the vessels. So I'm just going to show you a very brief edited video of right upper lobe single port lobectomy for this tumor, which is sort of moderate size. Let me click on that. Okay, so this is a typical wound that we use in the anterior axillary line, about 4 centimeters. This is Storr's 5 millimeter angulated endo-sucker dissector to free up the superior pulmonary ligament, the inferior pulmonary ligament. And also, we use a lot of this diathermy forceps to free up the mediastinal reflection, as well as a lot of dental pledgets mounted to free up the vessels. This case is quite lucky because the fissure is almost complete for the right upper lobe, and this is the superior vein. This is just a regular instrument that we use, just a right angle or a Roberts, just to dissect out the vessels. And in a similar way to 3-port VATS, we need to free up a lot of the adhesions and the reflections clearly before we staple the vessels. We like to put a silk around the vessel to help us place the staple across. This is a echelon flex. I think it's a powered flex we use for this particular video. And you can see that going through from the single port front wound across the superior vein. So behind that, of course, is the artery. Need to free up again a lot of the tissue from the hilar and around the top, and some routine VATS instruments to go around the top and the bottom of the ascent of the truncus branch going to that right below. Again, we sling around a large silk to facilitate placing the stapler. see the staples being fired very smoothly and nicely with the power stapler. So that's the arterial branch divided. We go superiorly and find the bronchus there, the white structure in the middle of the screen. And again, you see the cartilage rings there. And then we free up the top and the bottom and place stapler across it. We quite like to crush sometimes we like to crush the bronchus before we put the stapler across it. But these days with the staplers, they're very good because the compression is very good. We do further dissection of the other small branches, the artery, segmented branches, and then we just complete the fissure. It's all from the front. You can see the cameras looking at the staplers all from the front view. Some lymph nodes, interlobar lymph node dissection. We also do the subcarinal, reflecting the lung anteriorly, and this is the paratracheal area that we search out and look for lymph nodes, etc. Great. So we've also done pneumonectomies, single port pneumonectomies. I don't have time to show the video here, but it's on the website that I was showing you with the first Asian single port meeting, and can be accessed by anyone. So these are some of the photos for the pneumonectomy single port. So a couple of slides for the future of single port VATS, major lung resection, I'd like to share with you. Dr. Gonzalez-Rivers, who performed the first lobectomy, said that we expect further development of new technology with more angulated staplers, robotic arms that open inside the thorax, and also wireless cameras, which will probably allow a single port approach to become our standard surgical procedure for major pulmonary resections. I believe the future of single port VATS surgery is in Asia. I think, first of all, Asia has a lot of the population needing lung resection surgery and where all the cases are. Secondly, I think in Asia, the diversity of the VATS technique is very wide and interesting across Korea, Taiwan, China, Japan, etc. And a lot of people are using different techniques, and it's the adaptation of the three ports techniques in those different areas into single port, which I'm particularly interested in. And I think exchange in experience and techniques will push forward this whole area. For example, in Taiwan already, Dr. Liu from Sun Yat-sen Cancer Center is already performing single port VATS lobectomy. And following our meeting 2 months ago, several more centers in Taiwan are also performing single port VATS as well. Of course, Professor Kim in the audience has also performed a lot of single port VATS lobectomy as well as some segmentectomies as well with great success. So the other part of the future of single port, I think, is in the instrumentation. In the future, I think better lens systems, maybe smaller lenses, smaller scopes, as well as a 3D system may facilitate single port VATS technique. Also better staplers, smaller diameter staplers, more flexible staplers, and lighter staplers may help us to do single port VATS. As you know, we humans are very innovative. We design a lot of complex toys to entertain ourselves. I think in the future we can see rapid development of staplers into something almost science fiction, for example, where you can drive a stapler into the chest like this, and you can have a very, very small wound, or you can jazz it up a little bit and make thoracic surgery very cool by putting a few extra things on it with lights and, and spoilers and also cameras. The third thing about the future, I think, is education in the Asia region. I think the technique has to be teachable, it has to be reproducible, and also have to be adoptable, and hence allowing it to be more widespread. And that can be done through lectures, videos, and animal wet labs, and also live surgery in the region. And lastly, but not the least, is research in this single port area. A lot of questions, in fact all of them, are unanswered for single port major lung resection. Is it safe? Are there benefits with it? For example, in terms of pain or surgical access trauma, hospital stay, chest drain duration, air leaks, etc. and also for oncological clearance. Is there at the margins, is it worrying for this technique? Are you doing the same surgery in the lymph nodes in terms of dissection? And also the recurrence and survival being the benchmark that we have to look at in future research. So I'd like to end the talk with this slide. This is a quote by Michelangelo, who's an Italian Renaissance artist as well as a philosopher. He said that the greatest danger for most of us is not that our aim is too high and we miss it, but it is too low and we reach it. So I ask you all to strive for a higher plane. Thank you very much for the opportunity.
Probably you can accept some questions from the floor. Just some questions and comments from the floor.
That's really
Yes, I have a question or just a comment that when we do single port, I think it's advantageous the surgeon holds the camera. I've seen to do better with that. And we have tried a 3mm camera, but it's just not enough light. You know, it's very hard, difficult to see. A wound protector would be very important. Get rid of the Wheatlander. If you use a Wheatlander, it's called a WATS procedure, W-A-T-S, so it's not really the same thing. And the last is, we do a lot of laparoscopic pericardial windows. We just make 2 incisions so there's nothing in the chest and so forth. So that's another, nice safe technique. But I applaud you for your success, and I agree, a smaller stapler would be nice. Over time, small diameter, but I really enjoyed your technique.
Yeah, thank you very much. I think your laparoscopic pericardial window was also suggested by some of our general surgeons in our hospital, possibly through the umbilicus, and that will mean that there will be even less wound or scarring for the patient. In terms of single port, there are a lot of development in the technique, as you quite rightly say. Some people use wound protectors, like a sort of rubber thing around it. Some people have tried using like a SILS thing, single incision laparoscopic surgery port thing to do it. But I think that's probably not necessary because you're not inflating CO2 in the lung for a lobectomy, so you don't need the airtight seal. But I think it's exciting because a lot of people are trying new techniques in China, Taiwan, Korea, and they're adopting their 3-port technique into trying to make it single port. And where they put their utility incisions for the 3-port technique is quite variable within the Asia region. And it's interesting to speak to other people and see how they can actually do the single port and get the angles of the staplers through where they put the utility thoracotomy. So
I think too, for our single port, we start off with a trocar or CO2 insufflation, because it really pushes, even though we got a double lumen tube in, it really pushes down the lung a lot quicker.
Right.
Sometimes we just got that seam, it takes a long time to get the lung down. So putting CO2 in initially and then removing that, making your incision a little bit bigger is really, help cut down the time.
Absolutely.
Yeah, excellent presentation. Just, for the Asian people, the intercostal space is usually very narrow. So many instruments put inside the one incision. Probably, I guess there is some hurt in the intercostal nerve. How about your pain after the post-operative surgery? The minimally invasive surgery, the most, the big one is less pain compared to thoracotomy. What's your opinion about that?
Yeah, I think for the single port, most of the compression of the nerve will probably come from the big, thicker thoracoscopes if we're using the bigger, for example, the 120-degree scope by Storrs is, I think, 11 or 12 millimeters. So it's even slightly wider than a normal scope. We're beginning to use a 5-millimeter 30-degree angulated lens. The one by Olympus is actually only 8 or 9 millimeters with like a bronchoscopic tip, flexible tip. So you can choose your instruments to minimize the nerve injury, but it's difficult with such a small incision. We normally perform the skin incision around 4 centimeters, but at the intercostal muscle level, to be honest, we will be extending it by around 2 centimeters, 1 to 2 centimeters either way, because you need that leeway to get the tissue out anyway, the lung lobe out anyway. because you need to release a little bit more intercostal muscle to get the ribs to come apart, to get the specimen out. So we normally do that from the beginning, and then that gives you a bit more access and possibly less injury to intercostal. We haven't done a study on pain. That's something that we need to look at and is in progress. And also a lot of inflammatory markers and things like that we're actually in the process of doing. So we're repeating the whole thing that's been happening 15, 20 years ago with VATS and open, 3-port VATS and open, in looking at all these parameters. I think before we can make this, prime time.
Thank you.
What about the operation time? Did you find any difference between the 3-port lobectomy versus the 3-port? Does it take a longer time, or is it about the same?
Yes. To start with, I think the first 8 or 10 cases, it took around an hour longer. It's mainly to get the angles, to make sure you don't fight with your assistant, and sometimes swapping places with the assistant to optimize your staple line and so on. But I think afterwards, once you've got a routine for the different lobes, then I would say now it's pretty much the same as a 3-port. Yeah.
Are there any questions that come from the floor? I have one question. How do you train the camera person? Surely you need to get some good assistant to help you.
Yes. We have 1 or 2 surgeons who are we try to train to do this single-port VATS, to hold the camera, and we'll try to use them, sort of get them to help us every time to do this. In terms of camera, actually you don't need to move it too often. Most of the time it's placed at the top of the wound, so I have to hold it at the top of the wound against the edge of the wound, and sometimes you have to change it at the bottom of the wound, but not too much movement. The camera person actually get used to it quite quickly because they're looking at the view in the same line as the surgeon, not like 3 VATS where you're operating like this and they're looking at it from sideways. So the junior guys do pick it up quite quickly because you're looking at the same vector. Yeah.
Yes.
Thank you. We are only one procedure during the operation, but the technique is very different. I have to ask you about the learning period. How many pieces is supposed to be kept in the period view?
How many cases? Sorry? The learning period. Well, I'm still learning, I have to say, very much so. I think around maybe 50 cases, 40, 50 cases is enough. Obviously, you have to have good experience of VATS in general before you proceed with single-port VATS. Having said that, following our symposium 2 months ago, there were 1 or 2 groups in China and Taiwan who have gone from open straight to single-port VATS without ever doing 3-port VATS, because the view or the direction of the incision and the dissection is quite similar to the open approach. So, and they have been, they've written an email to me saying that they've been successful. So it's not a prerequisite that you have to have a lot of 3-port VATS training, I think, before you can try single-port VATS.